Well, I'm Dr. Raj, and I've been doing this for quite a long time. So, really brief introduction, then we could jump into pulmonary and all. So, anyways, I teach step uno, dos, and tres. That's one, two, and three for the non-speakers, and I've been doing it for quite some time. And I also teach IM board review, and I actually work at USC, where you're actually in my super messy office at USC on a Saturday morning, exactly where I like to be. So, anyways, quadruple board certified. I teach pulmonary, critical care, sleep medicine, and I'm also internal medicine certified, and I kept it. So let's talk about pleural effusions first. So when we talk about the pleura, remember that the pleura surrounds the entire lung, and the pleura surrounds each individual lobe of the lung. And by the way, everyone, how many lobes do we have on the right lung? Mm-hmm. How many lobes do we have on the left? Two. And the pleura surrounds each individual lobe. And therefore, the pleura form the what? That separates each lobe of the lung. What's the word I'm looking for? Oh, the sac. No, it's not the sac. It's called the fissure. You have fissures. You have two fissures on the right and one fissure on the left. I like the sac. I never thought of that before. All right. And remember that you have two pleura, the visceral, which is smacked up against the organ, the parietal smacked up against the chest wall, and you are constantly making pleural fluid, and it's constantly getting reabsorbed. So when you actually see pleural fluid there, that's not a good thing. So when we talk about, the pleura, oh, look, here's our minor fissure, our major fissure. Here's our one fissure on the left. So remember, three lobes on the right, one lobe, two lobes on the left, and the pleura also form these fissures. So I purposely put this here for a couple reasons. Number one, on your USMLE Step 2 in the pulmonary section, if they were to ask you, what is the best first initial diagnostic test, chances are my number one answer would always be what? Chest x-ray. It's going to be your default answer. You know what I mean? Just like cardiology, best first initial diagnostic test will always probably be what? EKG, you know what I mean? So even in the pleural effusion realm, they're going to start off with a chest x-ray. So class, does everyone see the abnormality or where the abnormality is in this chest x-ray? Yes or no? Yeah, cool. Most people say yes. So what lung is involved, the right or the left? Okay, correct, the right. It's the right lung. And what stuff on the right, what lobes are involved on the right? So let's stop right there. Everyone's kind of getting it wrong. It's going to be the right middle lobe and the right lower lobe. And how do I know that is because I don't know who's teaching your imaging, but hopefully it'll go over this, is that right here is called the right atrial border. And when you don't see the right atrial border, because I don't see it, it's silhouetted off. And when it's silhouetted off, that means whatever density is there is going to be involving the right middle lobe. The right lower lobe is also involved because I don't see the what? The diaphragm. So if you only don't see the diaphragm, think of right lower lobe. The minute the right atrial border is shadowed off, also right middle lobe. So let me ask you this. If you see this density, can you call this a pleural effusion? Yes or no? Oh, ouch. Let's stop right there. The answer is no, you can't call this a pleural effusion. You can't. All you could do is what? Describe. And what can I see here? I only can see a density that involves the right middle and right lower lobe. This density could be what? Consolidation. It could be atelectasis, or it could be what? Effusion. You just don't know. So how am I going to determine that this is a pleural effusion for the board exams? Because all you do is got an x-ray first. So what are things I can do to tell me it's a pleural effusion. So everyone says that the next best step in evaluating this chest X-ray pleural effusion is thoracentesis. So when I think about that, always think of your patients on your board exam as someone you love, like your mom. So if your mom came to me with this chest X-ray, I'm like, well, it could be a pleural effusion. Let me find out. Well, how, doctor? I'm going to take this needle, I'm going to shove it in your mom's back, and I'll pray that fluid comes out. Does that sound like the next best step in evaluating the pleural effusion? Yeah, I think all you people who said thoracentesis should call your mom like right now and apologize. That's really mean. So how do we see it's a pleural effusion? There's a bunch of different ways. Number one, you can make the patient go on their side. It's called a lateral decubitus to see if there's going to be a layering of this density. That's cool, but let me ask you this. Can you do a lateral decubitus film and you don't get a layering of the fluid? And the answer is yes, but it still could be a pleural effusion, and maybe it's loculated or something like that, you know? So you could do a lateral decubitus, you could do a CT scan, but that's money and contrast. And let me be honest, a CT would not be the next thing I'd order, because if you wanted to help you before ordering the CT, I would probably want to drain the fluid out first so I could see the lung parenchyma. So in clinical medicine, I give my fellows and residents a little pep talk when they CT right off the bat, because I'm like, dude, the CT would have been more helpful once you drained the fluid. You know what I'm saying? So what would be another practical thing to do? Ultrasound. Because not only I could make the diagnosis, I could actually drain it. But on your USMLE Step 2, they like a lateral decubitus first. And if you can't get a lateral decubitus of choice, they love ultrasound, because you can do diagnostic and therapeutic at the same time. And CT is not a wrong choice, but it's not as helpful if you do it up front. So let me show you a couple pics. There is a CT of the same patient. You can clearly see the fluid here. But this is my favorite one, ultrasound. You put the probe on the back. Look at this huge pocket of fluid, same patient. And now you can make the diagnosis and you can do the thoracentesis at the same time. All right, so anytime you have a fluid anywhere in the body, peritoneum, the joint space, wherever, you got to put it in a broad category. What causes fluid to be there? And on step 2, the two main flavors of pleural fluid are going to be, is it a transudate or is it an exudate? So well, this is a weird question. Is the ultrasound also allowed to decubitus? No, ultrasound is an ultrasound. You get an ultrasound probe and you put it on the back. A lateral decubitus is an x-ray. Lateral decubitus is the positioning of the patient. You do a lateral decubitus x-ray. You make the patient literally lay on their side. So they're two totally separate things. All right. So when you talk about how do I know if it's going to be a transudate or an exudate, well, there's always going to be something called Light's criteria, which you need to calculate as far as the criteria to figure out which one it's going to be. But before we get to that, since I'm on this slide already, let me talk about the two choices, transudate and exudate. So when we talk about a transudate, then what are the most common causes of a transudate? Well, those are going to be things that are going to be manipulating Starling's forces. So remember, Starling's forces are two things. Things that will increase the hydrostatic pressure or things that will decrease the oncotic pressure. So it shouldn't surprise you that for hydrostatic pressure, it would be CHF. For oncotic pressure, you got to think about a nephrotic or a cirrhotic, not losing protein or not making a lot of protein. But do me a favor, class. If you wouldn't mind writing in your notes that two of my favorite causes of transudates are, number 1, atelectasis, so remember that, and number 2, pulmonary embolism. So those are also going to be causes of transudative fluid right after all those Starling's forces. So What about exudates? What are going to be the most common causes of exudates? Don't copy any of this crap I put here. I'm just going to make you angry. For a third and fourth year medical student, you need to know that the two most common causes of an exudate are always going to be infection and malignancy. That's going to be 80% plus of all your exudates are going to be one or the other. And then, of course, there's everything else, which is lower in yield. But class, if you don't mind, can you write down one thing for exudates that they love? Look at this one over here. What does that arrow point to? Pulmonary embolism. So yeah, you got it, man. Pulmonary embolism will both be can be a transudate or can be an exudate. So it likes to play both fields. And you know, Kaplan likes that kind of stuff. Things that could be kind of both. You know what I'm saying? So those are the ones that I definitely would know for the board exams. And we'll go over some of the finer points in a second. But now we're going to double back and say, well, how do we make this knowing it's a transudate or exudates? You have to use Light's criteria. So when we talk about Light's criteria, once again, let me double back because I could see people asking some questions that they didn't maybe pick up on. If you have a pleural effusion, trust me, you're going to have some kind of respiratory symptom. You have a respiratory symptom, you should shoot a what? Chest x-ray. Then you see a density there, and the keyword is density. You don't know what it is. Is it consolidative, or is it going to be an effusion? So your choices are CT, ultrasound, or loud decubitus. To get a loud decubitus, you have to reshoot the x-ray, but you make the patient sit on their what? Their side. Or you do an ultrasound, or you do a CT. So now you know it is fluid in nature. Once you know it's the fluid, then and only then you could do the thoracentesis. And when you do the thoracentesis, you want to use Light's criteria. And Light's criteria are three things. It's comparing the effusion to serum LDH, the effusion to serum protein, and the total LDH. So there are three of classic Light's criteria. There's three of them. So, and let me ask you the classic questions. How many of Light's criteria have to be negative to be a transudate? How many? Good, everyone's correct. All three have to be negative to be a transudate. How many of Light's criteria have to be positive to be an exudate? Most of you guys got it right. One. Only one. So now let's go back to something you guys love, biostatistics. And I was just joking. I know no one likes it. So Light's criteria for a transudate is very one, sensitive or specific. And I could tell that no one likes it based on the answer choices you're giving me. The answer is specific. And why do we want to be very specific for transudates and very sensitive for exudates? Is because class, what are the two most common causes of an exudate? Infection and malignancy. Do you want to miss that diagnosis in the patient? The answer is what? No. And that's why we're willing to be sensitive to get all the true positives and all the false positives. CHF, nephrotic, cirrhotic, they're not going to die from their pleural effusion. Trust me, they won't. And that's why you better be damn specific if you give it that diagnosis. Remember, it only takes one to be an exudate. Good. So when we talk about these pleural effusions, a couple things I just wanted to say is that if they were to ask you about the chest tube, for a third and fourth year medical student, they're going to keep it simple. If there is pus that is seen from the pleural space, we call that empyema. If they say it's a complicated effusion, if it's a loculated effusion, and this is a CT of a loculated effusion. See how it's very lobulated, it's not free-flowing? If the pleural fluid says it's a positive culture or positive gram stain, you want to have a very low threshold in putting in the chest tube. Classic one for 3rd and 4th year med student is it's empyema. You got to bust out a chest tube. Good, because antibiotics in itself won't be enough. Then, when we talk about the pleural fluid findings, don't copy any of this. Let me just say this, be very practical. Once you get the fluid, you put the patient through a procedure, don't be cheap. Order what you want. So things I look at, how many WBCs are there? More important than how many, what type? So if it's going to be a neutrophilic exudate, no big deal. Bacteria, bacteria, bacteria. The one I want you to realize that if it's a lymphocytic exudate, that's when the party begins. Because what are your two differential diagnoses for a lymphocytic exudate? Number one, it could be tuberculosis, and number two, it could be what? Malignancy. And you really need to determine which it is, because it obviously will change your management. And you're going to know the difference based on the history and the physical. Obviously, if they're HIV positive, just came back from India, Guyana, Asia. Oh my God, TB's high on the differential. You know what I mean? So you want to look about the cell type predominance. The two cells being, is it a lymphocytic or is it neutrophilic? Other things I would look at, the glucose. And remember, anytime you look at a glucose in any body fluid, the CSF, the peritoneum, the pleural space, you always want to compare it to serum glucose. But rule of thumb is a very low glucose in the pleural fluid is not a good thing. It means there's something cooking in there that's sucking up all the glucose, and that's no good. And I will say this, pH of the pleural fluid, well, the pleural fluid pH should be the same as our pH, around 7.4. If it's super low, that just means something nasty is going on in the pleural space. Let me just say that. Let's do a couple questions. 62-year-old woman is evaluated in the ER department for a 2-day history of increasing shortness of breath. She has advanced COPD with an FEV1 of 45% of predicted. She has a long-standing history of heavy smoking and continues to smoke, good job, 1 to 2 packs per day. Her current medications are tiotropium and as-needed albuterol. On exam, she's difficult to arouse. She's afebrile, normotensive, non-tachy, tachypnic at 25. Her BMI is 30. Pulmonary exam discloses prolonged expiratory wheezing. There's bilateral pitting edema of the legs. And her O2 stat is 93%. So 62-year-old female, ER, shortness of breath. You see how she's presenting? Question: which of the following is the most appropriate diagnostic test to perform next? Carrie, let's poll the class. In class, I'm going to do you a favor. I'm going to go back. Here you go. All right, let's stop the poll. Time's sake. So when I look at this question, this is someone who comes in, known COPD, and what would be the next diagnostic test to perform? And don't get me wrong, in the hospital, they'll probably get all this stuff. But which ones don't make a lot of sense to me would be number one, C. Don't get me wrong, she's going to get a CBC. But is that the test that you should do next of all those? Probably not. You know what I mean? I don't think it's going to change what you do. You know, the other one that I don't think needs to be done next or even at all would be what? CT. You know, don't get me wrong, every hospital will probably get one because we love to waste money. But is it really going to change what you do in this case of the way she's presenting? Is that the next thing she needs? In fact, in this patient, it would be very unsafe to get a CT in this patient. So I'm not thinking B and C. Why did the whole class pick D? I'll tell you why. because of this bilateral pitting edema. But I already mentioned this patient has what? Advanced COPD. And can I say why you ordered it? You were thinking what? CHF. But you know what this patient has? Core pulmonale. So the correct answer here has to be ABG. And I purposely put it here because I ripped ABG as a new one when we're talking about asthma in the acute setting. But this patient needs an ABG because it will change your management. And what is the three words I was looking at that say you need an ABG? The answer is what? Difficult to arouse. Because when you think difficult to arouse, you're worried that the patient may be what? Hypercapnic. And if the patient's hypercapnic, will that change what you do? Definitely. And what would you do if this patient's hypercapnic? Type it out. OMG. Stop right there, everyone. Why is this class so aggressive? Please do not intubate everyone. It's like you're just waiting to intubate someone. I'm going to say that what I would probably do first, especially because it's COPD, is probably non-invasive, like a BiPAP. So some people may say, well, she's difficult to arouse. She doesn't have any mental status. And that's true. I get a little hesitant putting BiPAP on people who are difficult to arouse. But with COPD patients, let me just say this. Any one of us could intubate them. Intubation is not difficult, trust me. But what's the hard part once you intubate this patient with COPD? Getting the patient off the vent. So the answer here is going to be what? ABG. Good job. Yay. 68-year-old man with a history of COPD. The FEV1 and PCO2 are measured at baseline. At baseline, the FEV1 is 550 mLs. The CO2 is elevated at 58. Patient is admitted with a 3-day history of cough and purulent sputum and shortness of breath. His only medications are an inhaled beta-2 agonist and inhaled anticholinergic. The patient is 65 kilograms, like a small, tiny dude. Patient has low-grade fevers, and patient is tachypnic and has an irregular heart rate of 120. Class, if you are a COPD patient and you say the word irregular heart rate, what's the very specific arrhythmia associated with COPD? Yeah, awesome, everyone. Multifocal atrial tachycardia. It could be. I just wanted to throw it out there. So in this patient, he is using accessory muscles. Breath sounds are diminished. His chest x-ray shows no pneumonia or heart failure or pneumothorax. So this guy is having a COPD exacerbation. They do an ABG on him on 5 liters of supplemental oxygen, and now his pH goes down. His CO2 goes from a baseline of 50 and change to 74, and what a coincidence, the EKG did show MAT. So in this patient with a COPD exacerbation, all of the following would be expected to lower his CO2 except. Now, I know on the USMLE there are no negatively rephrased questions. I'm quite aware of that, but I like it because it makes it a little harder. So why don't we do this one for the class? It has nothing to do with the vignette. Just look at this question. All the following interventions would lower the CO2 except. Let's stop the poll. So when we talk about this question, let's answer it in a positive way. That's how I would approach it for like a QBank or USMLE world. So which ones will reduce the CO2? If you decrease the amount of oxygen he's getting, I agree. His CO2 will go down. He won't retain. I agree with that. So A is correct. If you give the patient BiPAP, you strap this mask on their face or nose, you're going to do what? Blow off more CO2, so it's going to go down. So I think A and B are cool. It really comes down to C or D. And I guess the question of what makes everyone so hard is, does Tylenol reduce your CO2? What do you guys think? The answer is yes, it does. And you're like, Oh my God, why? Is because back to something evil known as step 1. What are the 2 things that actually regulate CO2 in the body? Number 1, minute ventilation. Number 2, metabolic rate. And anytime you increase your metabolic rate, what happens to CO2 production? Goes up. Anytime you reduce your metabolic rate, what does that mean? Less Krebs cycle. And what do you make from the Krebs cycle? CO2. So if you give an antipyretic like acetaminophen, what happens to your metabolic rate? Decreases. So what should happen to CO2? Go down. So the only question here is a benzo. You do not want to be loading up people in respiratory stress with benzos, because what's going to happen to respiratory drive? Decreases. I think I got one more thing. I love this one. Class, what reduces mortality in severe acute exacerbations of COPD? There's only one answer I'm looking for. There's only one answer that reduces mortality. What is it? And I like, don't get me wrong. I could appreciate half the class typing in the word steroids. You know what I mean? Because why not? If you don't know, what's the best answer? Steroids. But no, steroids hasn't reduced mortality. Oxygen doesn't reduce mortality in the acute setting. It definitely does it in the chronic setting. And of course, in the acute setting, do you transplant anyone in the acute setting? Come on, guys. It's impossible. There's so much criteria. The answer is always going to be, you're going to roll your eyes and say, I knew that. BiPAP. So when we talk about evidence-based medicine, I gave you the reference that you could read. But in the acute setting, you want to use non-invasive. And using BiPAP has oodles of evidence to reduce mortality in the acute setting for CHF and for emphysema. And how do I simplify it so you guys understand this? Is that, remember, anyone can intubate someone with COPD. It's not a big deal. The trick is getting him off the vent. So BiPAP, by wearing a mask to help out with that work of breathing, really prevents one thing: intubation. So that is why this is a 20,000 star high yield pearl for the board exam.